Hello, everybody. Have a nice afternoon. I'm very happy to be here to introduce this webinar on ERN on the ERN sequence of webinars, and is devoted to challenges in pericarditis. Now we will just wait another minute or so. Then we will start presentation of one case. It's a single case, but it's rather complex. So there will be two colleagues that will present this case, and there will be in particular Anna Baritussio and Andrea Giordani. They will do it in a very interactive way, and I hope it will be interactive also from the audience. But to be more efficient, please send me a possible question via chat, and 5 minutes before the ending of the webinar, we will select a few representative questions and answer to you. There is a recording of the webinar. It's already started. So if some of you are unable to follow this presentation, you can then it is recorded on the ERN website, so you can look at it later on whenever you are ready. You are not on call and you don't have other problems. So I think in just 1 minute, because I see that several people are actually now connecting. So just 1 minute, and I will give the stage to my colleagues to present this case. Actually, you can also start sharing.
Just to check, can you see my slides, our slides, and our screen? Perfect.
Can you hear us? All right?
Yes, we can hear you.
Perfect.
Thank you. Okay. So it's 3:05, so I think we can start. So good afternoon, everybody. I'm Dr. Giordani from the University of Padova, the cardiology unit, and let's dive into our case that we are going to present today. So our patient is a 62-year-old male patient. He's from Italy, he's Caucasian, and he presents to the ER for a 4-month history of progressively worsening dyspnea. He is an active smoker, and no other relevant comorbidities are found in the medical history, apart from a minor motorbike accident that had happened 6 months before, but the patient was conducting a very normal life. The patient presents to the ER and on the physical examination, signs of bilateral heart failure are present with jugular distension, leg edema, hydrocele, and on the EKG we found normal sinus rhythm, and as you can see here, just non-specific regularization abnormalities with diffusely flattened T waves. The chest X-ray confirmed the presence of a bilateral pleural effusion, and an abdominal US revealed ascites with a small amount of perihepatic fluid. From a cardiological point of view, the first step was to conduct an echocardiography that revealed only a mild reduction of left ventricular function, but also a circumferential pericardial effusion, as you can see here from both the parasternal and apical views. What is relevant in this case is also, as you can see from the subcostal view in this echo, relevant thickening of the pericardial layers apart from the congestion in the inferior vena cava. So now I will let Anna speak.
So hello everyone, I'm Anna Baitus, I'm a colleague here from Padua University. So we're talking about the pericardium today. So is there a role for imaging when we talk about pericardial diseases? And although we do know that pericardial diseases are clinical entities, of course, echocardiography, as shown also in our case, is a first-line imaging modality. Why do we use echo in patients with pericardial diseases? Well, first of all, because we can have a look at the presence of pericardial effusion, as was in our case. We can not only identify the presence of the effusion, but also look at the size, at the location, and looking at the echo characteristics, we may have some hints into the possible underlying etiologenesis. But when we find patients with pericardial effusion, as is the case of our patient, we need to look whether this effusion is hemodynamically relevant for the patient. So we need to look for signs of tamponade. And we do know that there are many features. Some are very specific, some are more sensitive. The most specific sign is the evidence of the right ventricular diastolic collapse. But we need to be aware of the fact that there are some conditions that usually delay the evidence of right ventricular collapse, as is the case of right ventricular hypertrophy, pulmonary hypertension, or severe left ventricular dysfunction. And on the other hand, there are some conditions that show this collapse of the right heart size a bit earlier than expected, and this is the case of hypovolemia. Of course, we do know that it's very important to look at the inferior vena cava, as Andrea has shown you, because the dilation of the inferior vena cava with minimal or no collapse is a very sensitive marker of tamponade. And of course, we want to look at the respiratophasic variation of the E wave at the mitral and tricuspid inflows. Of course, if we see that a patient has pericardial effusion, we want to know whether it is hemodynamically relevant, because we may consider to drain this effusion. And echo is very useful as well, because first of all, it defines the position of the effusion and is really relevant to identify the ideal entry site for the drainage, because it identifies the pericardial space that is closest to the probe, where fluid accumulation is maximal. And also we want to look for the position where there is no intervening vital organ. And last but not least, we can follow the needle with our probe, making the procedure much, much safer. Of course, when we think about the pericardium, we want to make sure that we assess the relevance of an effusion, but we should not forget to consider whether there is any sign of constriction. And we do know that there are some specific signs, as for example, the exaggeration of the expiratory and diastolic reversal in the hepatic vein flows. But we also have some sensitive signs, as the abnormal septal movement that usually shifts to the left with inspiration and then the opposite side during expiration. And of course, we do have some reference values for the respiratophasic variation of E wave at the mitral and tricuspid inflow, and a very important sign that we will discuss later, which is called the annulus reversus.
So going back to our case, in our patient, we evaluated the respiratophasic E wave variation to look for signs of constriction or tamponade, but they were non-significant. So our patient was not echocardiographically on constriction or tamponade. Speaking of lab tests, we had a slight elevation of C-reactive protein, normal BNP, normal troponin, negative quantiferon. The only microbiological test which was positive was the influenza A swab. Since we had a mild reduction of LVEF, we performed coronary angiography, which only showed a moderate stenosis of LDA. So we had a patient with progressive dyspnea, mild reduction of LVEF and a normal right ventricle on echo, negative troponin and non-specific EKG findings. So our differential diagnoses were FPEF or some sort of pericardial disease, taking into account the thickening of the pericardium and the pericardial effusion. What do the guidelines say with respect to heart failure and pericardial effusion? Well, it is very important to look for reversible or treatable causes of heart failure, especially if we have some kind of red flags such as pericardial thickening, such as in this case. And it is very important to consider second-level imaging modalities when we have, for example, subacute course of the disease, and our patient had a progressive dyspnea on over about 4 months. CT and CMR may be also useful to identify some key features such as calcifications or to further explore the role of pericardial thickening when we have a pericardial disease.
So what we did in our patient was to perform a CMR to look both at the myocardium and the pericardium, because if you recall, the two differential diagnoses were FPEF and some sort of pericardial involvement. So as you see here in these long axis CINI sequences, we note two things. There's a bit of thickening of the pericardium. There's a circumferential mild to moderate pericardial effusion and a borderline low normal left ventricular function that is further shown also here if the slides work. Yeah, on the short axis. You see also here on the short axis sinus that there is a circumferential mild moderate pericardial effusion. But we want to characterize a bit more both the myocardium and the pericardium as well. And as you see in these retroperfusion images, the myocardium is normally perfused, so there is no evidence of hypoperfusion. But if you take a further look here at the pericardium, which is a bit thickened, there is some evidence of mild hyperemia. And if we further characterize both the myocardium and the pericardium, we can perform T2-weighted images to look for myocardial and pericardial edema, and late announcement sequences, post-contrast sequences, to look for late gadolinium announcement. And as you see here, there is no evidence of edema of the pericardium and no evidence of late announcement of the pericardium. Why does it make, why is it reasonable to use CMR in patients with pericardial involvement? Well, first of all, CMR can help us assess the pericardial effusion, not only in terms of identifying the presence of the effusion and quantifying its extent, but also because by looking at the characteristic of the effusion in different sequences, we may have some information on the characteristic of fluids. So we are able to distinguish, or we can try and distinguish what is a simple effusion from, for example, a hemorrhagic effusion. But most importantly, we can tissue characterize the pericardium by looking at the presence of edema, as shown here as a very hyper-intense signal on T2-weighted images, but also use the novel parametric mapping to look at the increased T2 values of the pericardium, and also have a look at the pericardium on post-contrast sequences and searching for the presence of late gadolinium announcement, as you see here in this example. Of course, CMR can also be of some help when we have patients with constriction. We need to bear in mind that constriction is, first of all, a clinical diagnosis, as we said at the beginning. But as you see here, CMR can be very helpful as well, because we can spot the thickened pericardium and, most importantly, the abnormal septal motion on CINI images. And also, as we said previously, the septum moves in an abnormal way related to breathing at. And so we can ask the patient to keep on breathing, and rather than having CINI sequences in breath hold, we can require and acquire CINI sequences 3 breathing. And as you can see here, you see the abnormal septal movement with respiration. And last but not least, sometimes constriction comes not from the pericardium, but from outside the pericardium, and CMR may be useful in this case. As you see here, there is a mass anteriorly that it's compressing the heart from the outside, the pericardium from the outside, but it may also be very useful to see whether the pericardium is involved by not cases of pericarditis, for example, but when we have, for example, tumors that can involve the pericardium, as for example in cases of lymphoma.
So to come back to our patient, as Anna showed you, we had a normal myocardial tissue characterization and also absence of LGE or edema in the pericardium. The pericardium had only a mild degree of hyperemia, and the CMR confirmed the mild to moderate circumferential effusion in the pericardium. So going on, speaking with of multimodality imaging approach to pericardial diseases, well, multimodality imaging may be useful for assessing, for example, the myocardial involvement during pericarditis, for example, to exclude other thoracic diseases with CT, to further characterize the pericardial involvement with the CMR, CT, and PET, and also CMR can be used to guide therapy, for example, when we have a relapsing pericarditis. Well, in this case, we used CT because we wanted to assess any presence of calcifications in the pericardium, which turned out negative for calcification and only slightly hyperemic, with only a mild degree of pericardial enhancement. And with respect to other thoracic diseases, well, we only observed a small amount of reactive lymph nodes in the mediastinum, which were located in the mediastinum, but these were not clinically significant. So the final diagnosis was of a viral polyserositis. The patient was treated with oseltamivir, and on discharge, the patient had only a mild degree of pericardial effusion, which was clearly reduced compared to the previous echo I showed you. Well, is this case solved? No, because 1 month later, this patient presents again to the ER because he's not well, is unwell. This patient has now pleuritic or pericardial chest pain and a relapse of right ventricular failure symptoms. This time, CRP is negative, BNP is still negative, and also troponin is still negative. On the chest X-ray, it seems better than the previous one because now pleural effusion, is only present on the left base, while the right pleural effusion is now disappeared. And what happened to the pericardial effusion now? Well, this patient repeats an echo, and now we have still pericardial effusion, but this effusion is now severe. As you can see, we are facing a severe pericardial effusion, and also the inferior vena cava is dilated. And we wanted to assess again, due to the RV failure symptoms, any echocardiographical sign of constriction or tamponade, but respirophasic wave was again non-significant.
So we're facing again, the patient presents again and has similar history as the previous presentation, but we still have no clear idea of what's going on. So what we've asked ourselves is, are we missing something? So we go back to our tools in the pocket, sort of. So can imaging be of any help? So can we still have a look at something else? So what we decided to do was to repeat the CMR. And as you see here, we have clear signs now of heart failure, because you see here bilateral pleural effusion, quite relevant extent. We see again the presence of a moderate circumferential pericardial effusion. The patient is much more tachycardic than he was in the previous presentation, so it's more difficult to assess regional wall motion abnormalities. But maybe we can agree, or I hope you agree with us, that especially if we look on the short axis, although there is no clear septal bounce, the septal movement looks a bit odd. And you can see, or you can appreciate here as well on the short axis, the amount and the extent of the circumferential pericardial effusion. But once more, when we look at tissue characterization, we are a bit upset because it's not very helpful for the management of this case, because the myocardium is normal. It's good for the patient, but not helpful for us in the differential diagnosis. So there's no myocardial tissue abnormalities. And also the pericardium showed no evidence of edema, and there was also no evidence of pericardial late announcement.
So what to do now? Well, if you think of the multimodality imaging approach, we can think of performing a PET scan, and that's what we did. We wanted to look for any involvement of the pericardium or the myocardium, but there was no captation in these areas. The only hypermetabolic activity was seen in the left pulmonary base, so we performed a thoracentesis, but all the diagnostic assessment turned out negative, including microbiological analysis. This patient still had RV failure symptoms, was on diuretics, so we wanted to look for calcification in the pericardium because we were afraid of constrictive pericarditis. And again, apart from a mild thickening and inflammation of the pericardium, CT scan was negative for calcification. And we were starting asking ourselves, is constrictive pericarditis possible with a non-calcified pericardium? The diagnostic workup went on with a diagnostic pericardiocentesis with a drainage of about 350 milliliters of bloody pericardial fluid, but all the assessment on this fluid turned out negative. So what could we do next? Well, since non-invasive diagnostic methods were not conclusive, we opted for cardiac catheterization, which showed clear signs of pericardial constriction, because as you can see here, on the left and right ventricular catheterization. We could observe a clear deep and plateau pattern, also known as square root sign, which is very typical and specific of constrictive pericarditis. And also the right atrial pressure was still markedly elevated even after pericardiocentesis. And combining constriction and effusion in the pericardium, we had the diagnosis of effusive constrictive pericarditis in this case.
So what to do next? We have a patient who's presented more than once to our attention. We're still not very clear. We were not very clear, but now we have a diagnosis of effusive constrictive pericarditis. So the first thought was, shall we call the surgeon straight away because it's second presentation? But we still know from imaging that there is some evidence of inflammation of the pericardium on CT. So what shall we do? And we went back to reading a bit, and we remembered ourselves of this important conditions which is the transient pericardial constriction, because transient constriction occurs in up to 15% of acute pericarditis cases. And this is due to the fact that the inflamed and edematous pericardium is non-compliant, so it can have a constrictive behavior. And transient constriction, it's probably more frequent than we think, because sometimes it really is clinically undetected if we don't think about it, and it can be also very rapid, but in some patients it can last for several months. So if we look at the older guidelines, we will see what happens this year, but the older guidelines recommended a 2 to 3 month trial of medical treatment in patient with a newly diagnosed constriction without features of chronicity and with increased systemic inflammatory markers. Of course, on the second presentation, CRP was negative, but it was positive in the first presentation. And we want to share with you a case just to show you how important it is to think about transient constriction. This was a guy that presented with acute pericarditis, very markedly elevated C-reactive protein. As you see here, there's a sort of organized complex circumferential effusion with signs of constriction, as shown by the significant respiratophasic variation of E wave, both at the mitral and tricuspid inflow, and with evidence of annulus reversus. CMR was helpful in this case because it showed a thickened but heavily edematous pericardium with a lot of late announcement of post-contrast images. The patient underwent quite a prolonged guideline-based anti-inflammatory treatment, and following few months, he had a complete regression of the effusion, and all the signs of constriction disappeared as clinical signs of pericarditis, and also lab markers turned back to normal.
So coming back to our case, what can we thought now? Well, we had a patient with negative pericardial edema, negative LGE of the pericardium on CMR with a subacute presentation, relapsing RV failure. This time CRP was negative. Well, we achieved a working diagnosis of polyserositive of still undetermined etiology with signs of pericardial constriction. And sticking to the guidelines, we tried with indomethacin and colchicine as anti-inflammatory drugs, and the patient was discharged. The patient was then strictly followed up at our outpatient clinic, but 5 months later, despite we thought he was going well, he presented to the ER because, again, RV failure symptoms. So again, the third relapse. We performed third transthoracic echocardiography, which showed the presence of moderate pericardial effusion that we always saw in this patient. It was never, the pericardium was never normal. It was very, very thick now, and also we can see, we start to see an abnormality in the IVS movement, yeah, and also congestion of the inferior vena cava. For the first time, we saw mitral annulus reversus here in this patient because the lateral S prime wave was definitely inferior than the septal S prime on tissue Doppler. So we thought that the anti-inflammatory treatment was not useful in reverting the constriction of the pericardium, and after heart team consultation, the patient underwent pericardiectomy with a complete symptoms resolution. What is striking in this case was the histological examination results, because apart from the pericardial thickening and the absence of any calcification that we already suspected by the non-invasive assessment, we observed non-necrotizing inflammation with non-necrotizing granulomas, with also some rare giant cells, and the presence of non-tuberculous mycobacteria was noted. So the cause of this effusive constrictive pericarditis was infectious, especially non-tuberculous mycobacteria. So this is the end of our case, and we can think together with you we can speak of the challenges of this clinical case, speaking of etiology, diagnosis, and treatment. Well, discussing on the etiology, ECP is an uncommon disease, but in this case we had a peculiarly uncommon cause, because mycobacteria are not often cause of pericarditis, and especially in patients which are not immunocompromised and in non-endemic areas such as Italy. ECP can appear after iatrogenic interventions, but also chest trauma or infections, and the clinical onset may be very subtle and very difficult to recognize from the onset, with subacute presentations and RV failure symptoms, such as in this case. And what can we think of the question we had before? Is it possible to have constriction in the presence of a normal thickness pericardium? Well, yes, because as Anna said before, constriction can appear if the pericardium is physiologically impaired, maybe because of edema, but also because sometimes the volume of the pericardium may be shrinked due to the imbalance between the pericardial collagen degradation, which may be excessive, and a reduction in the production. So eventually the pericardium turns out to be of reduced volume, and also in the presence of a small amount of liquid of effusion, it can exert constriction. So here we have effusive constrictive pericarditis. The management of pericarditis in general is based on the cornerstone of aspirin or ibuprofen, so NSAIDs, together with colchicine, and the tapering of these drugs should be very slow according to both the symptoms of the patients and CRP levels, and it is very important for reducing the recurrences and the disease progression towards constriction. Going back to the guidelines again, the management of effusive constrictive pericarditis is based on pericardiocentesis and then on medical therapy to try to avoid anti-inflammation of the pericardium. If the case persists, so if inflammation and constriction and effusion do not resolve, surgery is the very last resource. Speaking of pericardiectomy, this is not an easy kind of cardiac surgery, but some patients may have a better outcome than others, as in this patient's case, male sex, post-inflammatory etiology, and absence of advanced heart failure symptoms are associated with a better outcome. So this is the end of our presentation. Thank you for your attention, and thank you to all of our team that helped us in achieving diagnosis.
So thank you very much for this presentation and the sort of state of the art about pericardial diseases, actually. We will be happy to, we are a little bit, you know, beforehand on schedule. So if there are any questions for us, we are happy to take them. I don't see any question in the chat. Please, Arthur.
Thank you. Thank you for this interesting case. Very well presented, beautiful pictures. How was the patient now ultimately treated? Now you have a very discrete diagnosis. And do you have follow-up of that treatment?
Yeah, sorry. Thank you very much for the question. So once we achieved the diagnosis of effusive constrictive pericarditis, we started treatment with anti-inflammatory agents, in this case indomethacin, which was given 50 milligrams 3 times per day, in association with colchicine, 0.5 milligrams twice a day. And we wanted to wait to send the patient to the surgeon to pericardiectomy, because we know that in some cases pericardial constriction may revert after correct proper course of anti-inflammatory therapy. So
okay, so I missed that, but the mycobacterium that you identified ultimately was not included in the treatment.
yeah, after pericardiectomy, we consulted the infectious disease specialist, and we started together with him antibacterial, antimicrobacteria directed therapy. But if I can add, the patient had not any other infectious symptoms apart from the pericardium. After pericardiectomy, the patient is now, after some
Doing
years,
well.
totally asymptomatic, totally well. We repeated also quantiferon test. TB search was included in all the microbiological analysis and in the cultures of both pericardial fluid and pleural fluid, and all of them were totally negative. So for us, it was a very unexpected finding to find this type of mycobacteria in this patient, but it was confirmed by histological examination.
Yeah, and quite challenging to get to the final diagnosis.
And if you would have known before the pericardiectomy, would you have treated the patient with antibacterial medication?
Yes, of course.
Yeah, at least tried it, right?
Yes.
At least tried, yeah. But we were not really expecting. I mean, this was really a shock. It was summertime. Do you remember, Alida? It was summertime. We got the response back, and it was really like, no, something is wrong.
Yeah. Thank you.
Yeah, I mean, this is a very peculiar case in many instances. First of all, because there is a discordance in the first episodes between inflammation on imaging, like CMR, and absence of pericarditic chest pain. Whereas in the following episodes, it was vice versa. We did not find any longer that much inflammation on cardiac imaging, but the patient had this time pericarditic chest pain. So overall, we, and according also to the guidelines, we decided anyway to have a course of anti-inflammatory therapy since there was also a progression of the effusion. But with no luck. I mean, there was no response after a proper anti-inflammatory cycle. So the patient was definitely swifting towards constrictive pericarditis. We had also, I mean, clear hemodynamic features of constriction with a deep plateau pattern, and so. And also on echo, we had all the findings, imaging findings, suggestive of constriction. So in the end, we decided to go to present it to the surgeon, and we were right indeed, because then finally the patient was well, and that's why it was quite shocking. The result that we had on actual the pericardial tissue. So we then, decided to discuss this with the infectious disease specialist, and he was also very surprised. But anyway, now after long follow-up, the patient is now fine, no signs of heart failure, and no complications from pericardiectomy. And so this is in other cases. I mean, we could have presented also another case. Anna mentioned a transient case of constriction. It was a young patient. Anna, would you comment on the second one? Well, what are the differences about the two and among the two cases, between the two cases?
Yes, thank you, Alida. Um, yes, we have actually a couple of cases over the last year and a half of patients with a clearly acute presentation, so not a long-standing history of symptoms, really acute pericarditis cases that had evidence, first of all, on echo of constriction with all the proper findings, respiratory heat wave variation, annulus reversus, septal bounds, as you would expect in a constricted case, but they missed the long-standing history. They didn't have calcifications. The pericardium was, of course, quite thickened. And these cases did show, all of them, we at least have 3-4 over the past year, they all had evidence of acute inflammation, also on imaging, specifically CMR, but some of them also had CT. And what we decided to do, as per guidelines, was to have a proper trial of anti-inflammatory treatment. And we then monitored the patient, of course, clinically and with lab findings, but also with echo and CMR. And what we saw over time was that with the regression of edema, or let's say inflammation on the different imaging modalities, CT or CMR, and with the progressive reduction and normalization of CRP, also the signs of constriction disappeared. So we had some of these patients were discussed with the surgeon acutely because there was really very bad constriction, especially in one case with proper heart failure, pleural effusion, ascites, need of high doses of diuretics, and just with anti-inflammatory and, of course, a very, very close outpatient follow-up, we could manage to tailor anti-inflammatory treatment and have a complete regression of constriction. And all these patients, but one, are now doing very well. So it's just one that doesn't have signs of inflammation and still has some septal bounds, but all the others have heart back to normal, I would say.
Any other questions from the audience? I can't see any on my chat. No, but anyway, I would like just to, let's say, comment that constriction is a rare event in pericarditis. I mean, we have now about 300 cases of pericarditis on follow-up, and only 10, probably even less, had either a transient or a chronic pericardial constriction. So definitely there is a spectrum of cases. There are some cases that unexpectedly develop very early constrictive pattern, but if there is a clear inflammatory signal and pattern, and there is a proper anti-inflammatory treatment, not only maybe just with non-steroidal drugs and colchicine, but we can also add steroids in this case, then they really resolve. Whereas, on the other hand, the worst cases do not have a clear clinical inflammatory onset, and they present like heart failure, basically, with a preserved ejection fraction and no clear history onset of the disease. So with a silent and insidious onset, and these are the worst of them, and not necessarily there will be calcification of the pericardium. Not necessarily. I mean, you may have pericardial constriction even in the absence of a calcified pericardium. So it's very important to fully study this patient, both clinically with, of course, the CRP and then imaging. Multiple imaging can be very precious both to define etiology and also the stage, and eventually also the management of these patients. But once you have a clear constrictive pericarditis without inflammation, without inflammatory symptoms, it is quite important not to waste time and to undergo pericardiectomy, because that is the only real cure for this disease. Any other comment, question?
Maybe if I can just add,
Yeah.
Aida, I think
Sure.
suspicion is very important. You should suspect things and look for them, because otherwise you may miss some signs. So also looking at constriction, sometimes you don't have all the features on echo. So I think it's important, if the clinical scenario is consistent, to look carefully for all the signs, because sometimes you may have one, and if you see that one, you need to have an explanation, and at least you follow up the patient more closely. So I think that suspicion and searching for it, and maybe using all the tools that we have nowadays, is very helpful to reach a diagnosis. What do you think, Alida?
Yes, absolutely. But I would like also to comment that we do not know yet enough from the pathogenic point of view what drives constrictive pericarditis. I mean, the fibrotic route is a very rare evolution, and it is quite intriguing that the bad constrictive cases do not have a clear acute onset. So, and in a couple of cases also, there was a family aggregation. I remember a very bad constrictive pericarditis where two brothers were affected. So maybe also here, there may be a genetic predisposition, and also a different mechanism of evolution to fibrosis and to constriction as compared to classic pericarditis. I mean, I cannot remember many cases with, let's say, acute or recurrent pericarditis then going to constriction. So it's like having two different diseases. I mean, the main problem of acute recurrent pericarditis is that the relapses, but now the relapses are, let's say, managed easily with anti-IL-1 agents, particularly in Europe, anakinra. So this is not a problem anymore. Whereas constrictive pericarditis, it is still a very gray area and a very obscure and rare condition. It is the only pericardial disease that is really associated with a bad prognosis also, except of course the specific pericardial diseases due to neoplastic involvement, but I don't consider them as really pericarditis, of course. I mean, so. Any other comment? No? So, Arthur?
Just to thank you. This is a beautiful presentation. I learned a lot. Thank you.
So, I mean, pericardium is a very still unexplored area in cardiology, but as a sort of take-home message, it is very important that to remember that first, acute pericarditis can be easily cured according to a guideline-based therapy. There are two main things to remember. One is to follow the CRP in order to taper down anti-inflammatory therapy. This is a very, very important rule. The second rule is to use non-steroidal agents at a high dosage initially, and TID as well. I mean, if you don't use it in this way, it is very likely that pericarditis will recur. And actually, it is not a real recurrence. It's simply an episode that has not been adequately treated. Also, there are no, let's say, one should always remember that for pericarditis, you have to use a tailored approach, an individualized approach. There are patients where an acute pericarditis episode goes very easily, well resolves after a few weeks and 3 months of colchicine, and that's all. In other patients, you have to use longer periods of anti-inflammatory agents. Then you may have to change anti-inflammatory agent. Then you may to add steroids at low dosage and at anti-inflammatory, not immunosuppressive dosage, and then plus colchicine. And then as a last resort, you can use in anakinra. So it is very important not to be patient, to also to educate the patient. He or she has to know that CRP is very important, and that the tapering down of anti-inflammatory therapy has to be done once the CRP is negative. Otherwise, there is a risk of recurrence, a very high risk of recurrence. I mean, there are these few, let's say, tricks that should be known for having a tailored therapy of pericarditis. And once you use these tricks, usually you don't have that many relapses. Is much less than 30% of acute cases relapse, and only a tiny amount, maybe 10%, will need third-line therapy with anakinra. That's our, let's say, collective experience in our center, but is in keeping with also the experience in other tertiary centers that cure both pericarditis and myocarditis. Myocarditis is a different disease. So I'm sorry, I don't have any questions, but from the audience, I hope that a few people will have a look at this webinar as a recording. And of course, we are happy to help if they want to contact us via also CPMS on other challenging cases. We will be very happy to help.
Thanks a lot, Alida.
So,
and thanks also to Andrea and Anna, of course, for your wonderful contribution. Okay, I think then we can close this webinar, and I wish you all a very nice evening.
Thank you. Bye.
Thank you.
Bye-bye.
Bye-bye. Bye. Bye.